Hello friends, today we are going to talk about the acute aortic dissection and the pathophysiology and surgical management. My name is Dr. Harin Patel. I am an assistant professor in cardiovascular thoracic surgery in UNMICRC Institute of Cardiology and Research Department. Let's start. So before we start talking about the acute aortic dissection, let's discuss about the normal anatomy of the aorta. As you know, aorta is the largest artery in the body, and aorta has 5 anatomical segments. The first and most important part of the aorta is aortic root, which extend from the aortic annulus to the sinotubular junction. The second part is ascending aorta, which extend from the sinotubular junction and it extend up to the origin of the innominate artery. Third part is aortic arch. Aortic arch start from the beginning of the innominate artery and extend up to the beginning of the left subclavian artery. The fourth part is the descending thoracic aorta, which extend from the beginning of the left subclavian artery up to the diaphragm level. And the fifth part of the aorta is the abdominal aorta, which start from the diaphragm level and extend up to the bifurcation of the aorta. The normal anatomy of aortic root. There are 5 anatomical components which form the aortic root and which separate the left ventricular outflow from the ascending aorta. The first is the subcommissure triangle. The subcommissure triangle is nothing but the extension of the left ventricular outflow tract. As you can see on the left side of the picture, the left commissure triangle of the NCC is the fibrous continuation of intervalvular fibrous body, whereas the subcommissure triangle of RCC and LCC are the extension of the membranous body. The subcommissure triangle under the RCC and NCC face the RA, where the membranous body is located, and the bundle of His. It is very important while doing the aortic valve surgery because there is a chance that taking a suture might injure the body of His and patient may have a heart block. The second part is aortic annulus. Aortic annulus. There is no aortic annulus. Usually annulus means a circular structure which in aortic cases not exists because there is no clear distinction between the left ventricular outflow tract and the aorta. For all practical purpose, aortic annulus is considered at the nadir of the all 3 semilunar leaflet. As you can see on the left side, the left ventricle, the aortic annulus form imaginary line which is formed at the base or the nadir of the semilunar valve. The aortic cusp. Aortic cusp, there are 3 aortic cusps: right aortic cusp, left aortic cusp, and the non-aortic cusp. All aortic cusps are the main providing the sealing mechanism to the aorta, which prevent the aortic regurgitation. All 3 aortic leaflets are made up of 3 things. One is the free margin, which has a thickened circular node, which also called nodus of Aranticus, the Bailey, and the base. The right and left coronary artery arise from the right coronary cusp and the left coronary cusp. The aortic sinus of Valsalva. There are bulging seen on the aortic valve are called the sinus of Valsalva, which is named after the Italian anatomist Antonio Valsalva. The function of the sinus is not yet proven, but the vortex which is created by the sinuses help reducing the shear stress on the aortic valve, and also it helps in maintaining the coronary flow. The sinotubular junction, the distal part of the sinuses towards the ascending aorta together with the 3 commissure form the tubular structure, also called the sinotubular junction. Sinotubular junctions separate the aortic root from the ascending aorta. The dilatation of sinotubular junction can lead to aortic sufficiency. In our case, in our acute aortic dissection, it is very important because the dilatation of sinuses valsalva and sinotubular junction leads to uh, aortic insufficiency. Next, the anatomical factors contributing to aortic insufficiency. The first is the dilatation of the aortic annulus. As you can see, the aortic annulus takes away the aortic curves from each other, and you can see on the baseline the 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 angle of the NCCs become more obtuse. Though sealing force is not exist, so that's why it can lead to aortic insufficiency. The second important factor is the elongation of the free margin. Elongation of the free margin can lead to prolapse of the aortic leaflet, can lead to the aortic insufficiency. The third one is the dilatation of the sinotubular junction. As I said earlier, the sinotubular junction, usually the length of the aortic valve leaflet is the more than the sinotubular junction, which provides the sealing mechanism. When there is a dilatation of the sinotubular junction, the length of the aortic is not sufficient enough to provide the sealing mechanism, and the dilation can lead to aortic insufficiency. Now let's start talking about the aortic dissection. Aortic dissection is a part of the acute aortic syndrome. Acute aortic syndrome is a life-threatening condition in which there is a breach in the integrity of the aortic valve. They can present in one of the three forms. One is the aortic dissection, intramural hematoma, or penetrating aortic ulcer. We are particularly interested in the aortic dissection. Aortic dissection is an intimal tear that allows the blood to pass through the tear into the aortic media, splitting the intima into two longitudinally, creating the dissection flap that divides the true lumen from the newly formed false lumen. We will see further how it creates a false lumen and it propagates distally. The aortic dissection has traditionally been defined acute during the first 2 weeks of the symptom onset and the chronic when beyond the 2 weeks. For all practical purpose, the aortic dissection is divided into two by there are two classifications. One is given by the DeBakey and one is given by the Stanford. One is the Stanford classification given by the Daly and the Associate. As per the DeBakey classification, you can see on the left side, the type 1 is the aortic dissection arising from the ascending aorta and extending beyond the innominate artery. Type 2 is the dissection arising from the ascending aorta and it is confined to the ascending aorta. Type 3 is the aortic dissection arising from descending thoracic aorta and it is confined to the descending thoracic aorta. And type 3B is the dissection arising from the descending thoracic aorta, propagating retrogradely as well as the anterogradely beyond the diaphragm. The Stanford classification, which is given by Daly, classified the dissection into two, type A and type B. Type E is the dissection which is arising from the ascending aorta, involving the ascending aorta, and all the type B is the all dissection which is not arising from the ascending aorta. The predisposing factor of the aortic dissection are hypertension in most of the cases. Patient presenting with aortic dissection in more than 50 years of age, most of the common finding is hypertension. Hypertension is also one of the most common predisposing factor in a patient with type B dissection as well as the abdominal aortic dissection. Other factor contributing to the aortic dissection are the connective tissue disorder, mainly inherited and non-herited family disorder like Marfan syndrome, Ehlers-Danlos syndrome, Lloyd syndrome. There are also familial aneurysm and sporadic aneurysm also which can lead to development of the aortic dissection. There are also congenital anomalies which can contribute to the formation of acute aortic dissection, like bicuspid aortic valve and coarctation of the aorta. Bicuspid aortic valve is the most common congenital anomaly present in the population. However, not all the bicuspid aortic valve anomaly transmit into the aortic dissection. Patient with bicuspid aortic valve with other predisposing factor may present early with the aortic dissection. The coarctation aorta can lead to formation of the retrograde aortic dissection in the most of the patient. Trauma, mainly iatrogenic trauma, can lead to formation the aortic dissection in less than 0.5% of the patient presenting with the aortic dissection in the emergency department. Most of the time there are the procedure like catheterization and the percutaneous diagnostic and the intervention leading to formation of the dissection. Also transfemoral catheterization, post endovascular device placement, and also in rarely it can also happen in the post aortic valve surgery or any other cardiac surgery due to the transfemoral cannulation, aortic cross clamking, or at the site of aortic venting. Let's briefly talk about the degenerative disorder of the proximal aorta. Degenerative disorder of the proximal aorta, if you look in the histopathology, there is a cystic medial degeneration. What is cystic medial degeneration? If we see the aorta in histology, we can see there is a disappearance of mucous cell in the elastic media. As you know, aortic valve consists of the three layers: intima, media, adventitia. Intima is the thinnest layer and the innermost layer of the aorta. Media is the middle and the thickest layer of the aortic wall, and the adventitia is the fibrous in origin, the external most part of the aortic wall. In a cystic medial degeneration, the cystic space is filled with the mucoid material. There is also the elastic fiber fragmentation, as well as the elastic fiber thinning out. Here you can see the histopathology of ascending aorta of patient presenting in of aortic dissection. From left of A to D are the slide of patient with the medial degeneration. You can see if you go from A to D, there is an increase in the severity of the medial degeneration. In A and B, there is a mild to moderate medial degeneration, as well as the elastic medial thinning out and elastic medial fragmentation. C and D are the severest form of the medial degeneration. Okay, E to F, if you see, there is a patient of atherosclerosis. In a atherosclerosis, if we see, there is a atheromatous plaque present in the elastic media with the calcification. There is an asterisk which is showing the calcification. From I to L, there is a patient of arteritis. Patient with acute aortic dissection can also have the arteritis like giant cell arteritis or Takayasu arteritis. Here you can see there is a massive infiltration in the tunica media like lymphocyte, macrophages, and etc. From M to P, there is a patient of arteritis and giant cell arteritis, as well as the mixed lesion, where patient with arteritis can also harbor atherosclerosis, and patient with this mixed lesion can have a mixed picture projecting the infiltration as well as the atheromatous plaque formation in the elastic media. Let's talk about the inherited connective disorder of the proximal aorta. Most common and important syndrome of inherited connective disorder is Marfan syndrome. Marfan syndrome is an autosomal dominant disease with variable pattern. There is a mutation in the gene encoding the fibrillin 1. Fibrillin 1 is a glycoprotein present is an important component present in an elastic fiber of the extracorporeal matrix of the connective tissue. The prevalence of Marfan syndrome is 1 in 5,000 individual. Marfan syndrome involves the various systems of the body, including the skeletal system, ocular system, and the cardiovascular system. The other syndrome of inherited connective disorder is Lloyd-Dietz syndrome. It's also an autosomal dominant disease with a variable penetration. There is a mutation in the gene encoding the TGF-B receptor 1 and 2. Patients with Lloyd-Dietz syndrome have increased risk of premature aortic aneurysm and the aortic dissection. The another syndrome of this family is Ehlers-Danlos syndrome. It is also an autosomal dominant disease with variable penetration. There is a mutation in a gene encoding the collagen type 3. The defect in collagen type 3 present in the variable clinical manifestation. Patients with Ehlers-Danlos syndrome also have an increased risk of aortic dissection as well as spontaneous aortic rupture. These are the gained criteria for the diagnosis of the Marfan syndrome. As I said, Marfan syndrome is a systemic syndrome which includes the cardiovascular, ocular, skeletal, and the other system as well. Initially, the gain criteria was meant to diagnose for the Marfan syndrome, which include the major criteria as well as the minor criteria. Now, the modified or revised gain criteria for diagnosis of the Marfan syndrome includes the aortic root dilatation. It is the most common presentation of the Marfan syndrome. That is why it is included in the revised criteria of Marfan syndrome. Aortic root dilatation or dissection with ectopia lentis, aortic root dilatation in bracket more than Z score more than 2 times the N fibrillin 1 gene mutation, or aortic root dilatation and systemic score of more than 7 point, also suggestive of Marfan syndrome. The epidemic of the natural history, it's a very lethal condition with the overall incidence is 5.5 up to 5.5 per in 1 lakh population, and male sex predominate in the aortic dissection. The overall age of presentation is more than 50 years. And the patient who are presenting who are aged more than 50, the most common causes hypertension, atherosclerosis. The patient presenting below the 50 are young and the suffering from the degenerative disease like Marfan syndrome, aortolectasia, and etc. On the right side you can see it is very lethal condition that 40% die immediately after the onset of symptoms. The 70% die within the 24 hours and 94 die within the 1 week. And the cause of mortality is intrapericardial rupture, acute LVF, coronary arterial occlusion, myocardial infarction, and aortic rupture. The pain is the most common presenting symptoms in aortic dissection. It's abrupt onset, most severe, and it's a tearing in nature. Most common location is the anterior chest wall, sometimes in the interscapular region. Clinicians should be able to differentiate this pain with the myocardial infarction, pulmonary embolism, and the pericarditis. With available diagnostic modality, clinical symptoms, the elevated jugular pressure, small sign, cardiac biomarkers can help us differentiate acute aortic dissection from the other entities. On the right side, you can see the circadian rhythm of the onset of the pain in the aortic dissection and the seasonal variation in the onset of aortic dissection. You can see the early hours in a day are the time when patient experience pain, and these are the time when patient comes to emergency in for this pain. And the right side also you can see the seasonal variation. In the summertime, the frequency of aortic dissection is decreased compared to the slight increase in the winter time. There is no explanation for this variation, but observation has suggested the aortic dissection rate is increased during the winter time. Patient, apart from the pain, patient may have cardiovascular symptoms and the peripheral vascular complication. The cardiovascular system includes the aortic insufficiency because, as I said, the dilatation of the sinusoidal junction leads to aortic insufficiency. Patient may have elevated blood pressure, or patient may also have the hypertension. The elevated blood pressure is because of the pre-existing hypertension or the activation of sympathetic system. Patient may also experience the low blood pressure because of the cardiac tamponade or the cardiac acute LV dysfunction. Patient also present with patient may also present with the malperfusion symptoms, like malperfusion symptoms to the brain, stroke, spinal cord ischemia, the malperfusion symptoms to the viscera and the peripheral arteries. Patient may also present the loss of the one or the more peripheral pulses. Patient may also present, along with the pain, patient may also have the anuria. This is the picture showing the peripheral vascular complication and the associated mortalities. It is observed that one of the peripheral vascular complication exists, the mortalities increase tenfold times. When the neurological complication exists like stroke or paraplegia, the mortality is multiplied by 14% up to the 43%. When one of the distal peripheral pulsation is deficit, the mortality increased by 25%. And the visceral ischemia exists like renal ischemia or visceral ischemia, complication is increased by the 50%. So it is very important to diagnose the malperfusion symptoms when patient present with the pain. Now let's talk about the diagnostic modality. There are non-invasive as well as the invasive diagnostic modalities. Invasive diagnostic modality is not used nowadays. There are non-invasive modalities available, which is transesophageal echography, ECG gated CT, angiogram, MRI. The esophageal echocardiography is very easy for a very extent to diagnose the aortic dissection. It is very quick and easily available in the emergency room to diagnose the aortic dissection. It can determine the severity of aortic regurgitation, valve morphology, cardiac tamponade. Other available modalities: ECG gated CT angiogram. You can see on the left side, CT can confirm the diagnosis of the aortic dissection with the uh, diagnosis of the true lumen and the false lumen. It can also diagnose the type of dissection. It can also diagnose the involvement of other arch vessel, the extension, the penetrating point, the primary intimal tear can also be diagnosed on the CT scan. Other modality is MRI. As I said, the invasive cath invasive model is not used nowadays. Coronarangio, we don't do it in acute emergency situation except in patient who has operated earlier for CABG. You can see on the CT scan the origin of the false lumen and extending into the branch, extending the arch vessel and also going distally up to the diaphragm. It is a type A dissection diagnosed on the CT scan. Here, this is the picture showing the diameter which we take during CT scan and the ecography. As I said, measurement should be obtained perpendicular to the long axis of the aorta. On the CT and MRI, the root diameter can be measured from the commissure to the opposite side, or sinuses to sinuses, or sinuses to the commissure. When doing transthoracic ecography, the measurement of the aortic root from the leading edge of the anterior wall to the leading edge of the posterior wall should be taken to obtain the largest diameter. Here you can see the sinuses to commissure or the sinuses to sinuses diameter has been taken. We can see that when sinuses to sinuses when taken, the dilatation is 51 mm. When sinuses to commissure diameter is taken, it always gives the largest diameter available. Let's talk about the management of the aortic dissection. The goal of this pathology is to prevent death. As I said, it's a highly lethal condition, and to prevent the irreversible end organ damage, because patient, as I said, patient present with the malperfusion damage. All patients of the aortic dissection should be offered emergency surgical care unless patient not willing for the surgery. There are very few relative contraindication present when patient present with the irreversible deep coma. When patient is also suffering from the advanced debilitating condition with the limited life expectancy. Age is a relative contraindication, but as I said, patient is having age more than 80 years, suffering from the other comorbid condition, it's a questionable condition. When patient comes to emergency, comprehensive monitoring is initiated with the insertion of the ART line, CVP line, the continuous cardiac monitoring with the blood pressure, urine output, nasogastric tube should be inserted, and till the patient is shifted to tertiary care center for the surgery, anti-impulsive therapy is initiated. Okay, this is the 30-day mortality according to the dissection type. As I said, when the chart showing the different modalities offered to the patient in type A and type B dissection. The uppermost square showing the medical modality when offered to type A dissection. It is showing the very high mortality in patient with type A dissection. The green triangle showing the surgical treatment when it was offered to the patient with type B dissection. It is also showing a little bit higher surgical mortality. The yellow square showing the all patient including type A and type B, the overall mortality in both the patient. The red square showing a surgical modality when it was offered to the type A dissection. It is showing the comparable result between the all cause mortality and the medical mortality. It is showing the better result when it was offered to the type A dissection, and you can see the mortality is high in up to 14 days, and it becomes linear, or I would say stagnant. That is the reason why the type A dissection has been classified into two, the acute, which is less than 14, and the chronic, which is beyond the 14 days, because beyond 14 days the outcome rarely changes, and that is the reason why we should operate the patient as early as possible. And the lowermost blue triangle showing the medical therapy when it was offered to the type B dissection. Again, it is showing the very low mortality, confirming the idea behind offering the medical treatment to the type B dissection and the surgical modality to the type A dissection. The role of anti-impulsive therapy in type A aortic dissection. The pathological factors responsible for the dissection is not only the internal tear, disease, trauma, etc., but also the shape of the pulse valve, which also noted with the dp by dt. The shape of the pulse valve is the time during which the aortic pressure rises. See this right side, this is showing the aortic pressure, and the dp by dt denoting the time during which the aortic pressure rises. Our goal should be to decrease the aortic pulse pressure, but only decreasing the aortic pressure will not helpful, as you can see in the another image. When the only aortic pressure was decreased by the antihypertensive medication, what happens, because of the increased sympathetic innervation, sympathetic impulse, the pressure decreases, but not the dp by dt. Dp by dt instead increases. So the goal of the anti-impulsive therapy is to decrease the dp by dt. In the other way, we have to decrease the shearing force. The shearing force will decrease the load on the aortic valve, decrease, or it will prevent the propagation of the dissection further. The antipulsive therapy includes the intravenous beta blockers with esmolol, labetalol, and secondary intravenous inodilators with NPG and the nitroprusside. This is the recommendation of acute medical management of acute aortic syndrome. Type class of recommendation is one: when patient presenting in the hospital with acute aortic syndrome, prompt treatment of anti-impulse therapy with invasive monitoring of blood pressure with an arterial line in the ICU setting should be recommended. Also, patient with aortic syndrome should be treated with the aim of the systolic blood pressure to be less than 120, or the lowest BP, that is maintain the adequate end organ perfusion, as well as the target heart rate should be to 60 to 80. The heart rate and the blood pressure is achieved with the intravenous beta blockers. The patient with acute aortic syndrome, the initial management should include the intravenous beta blockers except in patient with contraindication. The surgical principle of aortic dissection, type A aortic dissection, includes the replacement of ascending aorta and the arch vessel. We need to reconstitute the dissection aortic layers proximal and distally in order to obliterate the false lumen, and we should be aiming to redirect the blood flow into the true lumen. Before we begin the aortic surgery, we need to evaluate the aortic root for the aortic regurgitation. There are few things we should keep in mind along with the clear anatomical description of the aortic root. There should not be any intimal tear reaching the aortic root. The aortic leaflet should be normal, and the aortic root should not be dilated. It's not fixed criteria, but ideally speaking, aortic root should not be dilated. As I said earlier, dilatation of the aortic root will lead to aortic insufficiency. When aortic root is marginally dilated, aortic root with resuspension of the commissure is considered for all possible purposes to prevent the further aggravation of aortic insufficiency. When one or more sinuses of Valsalva is severely damaged, when patient is a Marfan syndrome or any other connective tissue disorder, when the large aortic aneurysm is present, patient with aortoannular ectasia, complete aortic root replacement with a reimplantation of the coronary ostia is indicated. CBB technique and the neuromonitoring. For all practical purpose, temperature monitoring is must in aortic surgery for the organ protection as well as the neuroprotection. The esophageal probe, rectal probe, esophageal probe or the bladder probe can be inserted. Ideally speaking, two temperature monitoring should be available. One is for the neuromonitoring and one is for the visceral monitoring. The nasopharyngeal or temporal temperature monitoring give us the better idea of neuroprotection. For a neuromonitoring, transcranial Doppler, EEG, electroencephalogram or near infrared spectroscopy is available. You can see in the picture the pressure, the saturation should be 60 to 7% in the each side. When there is a decrease is more than 20% of the baseline, indicate there is a malperfusion to the one of the hemisphere and immediate action should be taken. For the CPB technique, two-stage venous cannula is inserted in the right atrium. The CPB technique includes the hypothermic circulatory arrest with the antegrade cerebral perfusion when arch vessel is involved and we are anticipating that arch vessel may require the surgical intervention. In such cases, selective antegrade perfusion is initiated. When only ascending aorta is involved, patient may not require selective antegrade perfusion and the hypothermic circulatory arrest, but when arch vessel is involved and patient require arch intervention also, hypothermic circulatory arrest with selective antegrade perfusion is initiated. The two-stage venous cannula is inserted in the right atrium, the appendage, and the antegrade cerebral perfusion is commenced at the range of 10 to 15 ml per kg. The vent is inserted in the left ventricle through the right superior pulmonary vein. In our setup, we initiate this cardiopulmonary bypass with the right femoral and right axillary or innermost artery for arterial bypass, and the two-stage venous cannula used for venous drainage, which is inserted into the right atrium. This is the pictorial diagram showing that CPB technique. Here for venous drainage, the two-stage venous cannula is inserted into the right atrium. The right axillary or in other sense innermost artery can be cannulated for the selective antegrade cerebral perfusion, and patient can be taken on bypass, and gradually patient is put on the hypothermic circulatory arrest and the distal anastomosis is performed. Once the distal anastomosis is performed, patient is de-air and patient is rewarmed and the patient is weaned off from the hypothermic circulatory arrest, and proximal anastomosis is performed during the rewarming phase. The surgery of the aortic dissection includes the ascending aorta replacement. Aortic ascending aorta replacement is also a surgery for ascending aorta aneurysm and the dissection which is confined to the synovial junction at the innermost artery, not involving beyond or proximally. As you can see in the picture that ascending aorta is dilated and is involving just at the synovial junction, not going into the root of the aorta. After midline sternotomy and going on cardiopulmonary bypass from the ascending aorta or from the periphery, from the femoral artery, and the venous drainage attained from the two-stage arc cannulation, what we do, we insert a retrograde aortic cannula to give retrograde cardioplegia solution, and once the heart is arrested, we open the aorta at the most dilated part and give the ostial cardioplegia. Once heart is arrested, The most important next step is to inspect the aortic valve and the coronaries. Carefully, aortic valve is inspected for any damage involving the aortic valve leaflet, damage or dissection going or extending to the sinuses or involving the aortic valve. If we are certain that aortic valve is normal, aortic leaflets are normal, extend the dissection is not going to the coronaries, we can simply replace the dilated part of the aorta and we can come out. For that, the graft size between 24 to 32 mm size is taken. Before we do, we need to inspect the aortic valve. If the aortic valve or the one of the leaflet free margin is elongated, we can shorten the enlarge free margin of aortic valve leaflet so that we can minimize the aortic insufficiency. Also, if the aortic free margin is elongated, we can placate the aortic valve free margin also to reduce the chances of aortic valve insufficiency. Once the aortic repair is done, we can fix the dissection flag proximally as well as the distally. The proximally at the aortic valve, what we do 5 proline sutures over Teflon felt inside as well as the outside, and we fix the dissection flap with the adventitia and the media. Circumferentially, over 8 to 10 sutures are taken and the aortic valve is fixed. Once the aortic valve is fixed, we take the desired size of the Dacron graft between 24 to 32 millimeter size and we suture over the Teflon felt. Once the proximal sutures are taken, what we do, we take the Follis catheter and pass the Follis catheter into the distalmost part of the graft and we infuse the 20 ml of saline into the Follis catheter to inflate the bulb of the Follis catheter. The distal part of the Follis catheter is connected to the cardioplegia line with we give warm plagia. Warm plagia will do two things. It will check the pressure and aortic valve leaflet as well as it will give us the sign of any bleeding point located in the proximal site. Also, it will give warm blood to the aorta. Once the bleeding point is identified, we take extra bite if required, and we also take a call of aortic valve replacement if at all it requires. Once we are certain that aortic valve is normal and there is no bleeding point found in the proximal aorta, we take out the Follis and we do distal anastomosis. For that, if required, the clamp to be shifted bit down to bit distally, and we take the distal anastomosis over the Teflon felt. Once the distal anastomosis is finished, we insert the cardioplegia line to dear the aortic graft. Once aortic graft is dear, patient is gradually weaned off from the cardiopulmonary bypass. Once patient is weaned off, we carefully examine the aortic valve, the function of the aortic valve and the bleeding point. Once bleeding point is taken care of, we take the take the patient to the ICU for the for observation. Before we move on to next surgery, I would like to talk about the pioneering surgeon of that surgery, which is the Dr. Hugh Henry Bental. Hugh Henry Bental was the professor of cardiothoracic surgery from the Britain. In fact, he was the first professor in the cardiothoracic surgery and who performed the first open heart surgery with the help of the cardiopulmonary bypass in the Britain. He is credited for the engineering the aortic root surgery with improved survival result and improved clinical outcomes. This is his first article showing the technique of aortic root replacement with valve conduit. Aortic root replacement. Aortic root replacement was a surgery was invented by the Bentel and the De Bono. This is a surgery is done when the aortic root is not repairable. In short, when aortic root is abnormally dilated, all the curves are abnormal or destroyed, or dissection flap extending up the sinuses and involving the coronaries, involving the aortic valve leaflet, there is no choice but to replace the aortic root. It is the lengthy, complicated surgery which is performed by the experienced surgeon across the world in a highly volume center. Once once patient is taken on the bypass, the aortic valve and the aortic valve leaflet are excised. The coronaries are harvested with the rim of the sinus tissue around it, approximately 5 to 6 mm of that. Once the aortic dissection is complete, the valve conduit is used to house it on the aortic annulus. The size of the valve conduit is vary, but it is between 24 to 36 based upon the BMI. There are commercially available Dacron graft with mechanical valve is used for the valve conduit. The aortic xenograft or aortic homograft can also be used. The stented bioprosthetic can also be used instead of the mechanical valve conduit. Once the valve conduit is housed on the aortic annulus, the sutures are tied, and then with the help of the graft cautery, the perforation is made in the graft at the proposed and desired site of the coronary insertion, and coronaries are implanted on the graft. If the dissection flap extending into the coronaries, and if we feel that there is a narrowing of the coronaries, the venous graft is used to bypass the aorta. The proximal anastomosis is done on the graft. Distal anastomosis is done at the in RCA it is the AM or distal RCA. In LAD it's a mid LAD, or it's if it is a left-sided valve, the both coronaries are independently involved, and the two grafts on the left side are done. Once the proximal anastomosis is done, the distal anastomosis follow, as I said in the previous slide of the aortic ascending aorta replacement. The distal anastomosis performed as per the same. In the remodeling the aortic root, the aorta is excised just above the commissure, 5 to 6 mm above the commissure, and the sinuses are inspected. The three sutures are passed from each commissure, and all three commissures are pulled upwards till all aortic leaflets go up centrally and merge with each other. The aortic graft is taken, and its one end it is tailored to make new aortic sinuses. The width of the aortic sinuses is the intercommissural distance of each curve when they are pulled up. The height of the neoaortic sinuses is the same as the width of the neoaortic sinuses. The three commissures are initially sutured outside onto the graft. Once all three commissures are sutured, then the rest of the aortic annulus and the remnant of the aortic valve is sutured over the graft. The coronaries are then implanted on their respective sinuses. The distal end follows the same as I said in the ascending aorta replacement. So another technique of valve sparing aortic root surgery is the reimplantation of the aortic valve, in which the aorta is dissected circumferentially at the level of just below the aortic annulus. You can see on the left side of the picture, the first image. The coronaries are harvested with the rim of the sinus tissue of 5 to 6 mm. The multiple sutures are passed from inside to the outside in the left ventricular outflow tract with the Teflon felt. There are multiple sutures of Prolene 20 or 30 are taken. At the level of NCC and RCC, you have to be bit careful because there is a membranous septum and just below it the bundle node of his is located. Once the sutures are passed from inside to outside, all three commissions are pulled upwards. The sutures is taken from all commission and they all sinuses pulled upwards till the level all the curves come together and co-opt centrally. This is the level at which sinutubular junction is located. The imaginary circle, which includes all three sinuses, is the reference point for choosing a graft for the valve sparing aortic root surgery. Then after, the desired size of graft is taken. In our practice, we choose graft according to the synovial junction size, as I said, and we add 4 to 6 mm on that. So we take 4 to 6 mm larger the size of the synovial junction. After that, a small triangular shaped segment is cut off, which will correspond to the subcommission triangle of NCC and RCC. Once it is done, the sutures which were passed from inside to outside, they are again passed into the graft, and graft is pulled down, and then all the sutures are tied on the outside of the graft. Once suturing is done, the valve cusp and the coronaries are inspected so that they are aligned correctly. This is a technically demanding surgery which requires tremendous effort and experience. The result, the early mortality of aortic dissection surgery is approximately 25 to 26% of the cases. It has improved over the decades. The predictor of improved mortality is improved diagnostic and the imaging techniques, improved surgical techniques, better microprotection, and the sophisticated CPP techniques, and of course improved surgical experience. Also, improved perioperative management also has resulted in improved mortality. You can see on the left side the earlier mortality was 35% of the all cases, but over the period of time it has come down and it is between 15 to 20% of the cases. Initially, the mortality between the hypothermic and non-hypothermic was variable, but because of the improved microprotection techniques and sophisticated CPB, there is no much difference between the profound hypothermic circulatory arrest and without profound circulatory arrest. The survival rate of patient having undergone Bental surgery of valve sparing surgery has improved. The 1 year survival is 60 to 70% of the cases. The 5 year survival is 55. The 10-year and 15-year survival is 37 and 24% respectively. The predictors of late mortality is old age, hypertension, progressive of the connective tissue disorder, cardiac comorbidities like aortic regurgitation and the coronary artery diseases. Also, the perioperative peripheral complication can also take part in the late mortality. These are the guidelines for aortic dissection. It is stated that in patient with Marfan syndrome and aortic root diameter is more than 5 centimeter, surgery to replace the aortic root and ascending aorta is recommended. It's a class 1 indication. There is a class 2 indication which state that in patient with Marfan syndrome, aortic root diameter is more than 4.5 and the feature associated with the increased risk of aortic dissection surgery to be offered. Which are the surgical features? Like family history of aortic dissection, rapid aortic growth means 0.3 centimeter increase per year, diffuse aortic root and ascending aorta dilatation, and marked vertebral artery tortuosity. In this patient, surgery can be offered in patient with Marfan syndrome in whom the aortic root diameter is 4.5 centimeter. Thank you.